Okay, good morning, good afternoon to all of you today. Thank you for taking time out of your busy schedule to join us today at the Institute for Safe Medication Practices for our webinar program entitled Part 1 of a two-part series on the pursuit of prevention, confronting drug diversion. My name is Matt Grissinger. I'm the Director of Education at ISMP, and I'll be your host for today's program. As we know, drug diversion is a serious problem that affects patients and health professional safety. Patients may suffer from suboptimal therapy if their medications were diverted, receive substandard care from impaired healthcare workers, or be at risk for adverse drug reactions or bloodstream infections if they are provided with medications they should not receive or adulterated products in place of the intended therapy. Now, one challenge for health facilities is the requirement to secure and dispose of controlled substance waste every day, some of which require specific handling and protocols for safety. Healthcare organizations that use controlled substances must maintain detailed records and require drug disposal to be witnessed. Part 1 of this two-part series today will highlight how to confront drug diversion through the lens of the drug diversion program manager. I also want to thank Fresenius Kabi for the generous support for this program today. And let me go over some quick housekeeping items. This program is being recorded and will be available on the ICP website probably within next week. The handouts for today's program can be found using the link provided in the reminder email you received earlier today, as well as in the Zoom chat box as you see at the bottom of the screen. In fact, I put the link to the handouts in there right now. Also, all attendees are on listen-only mode during the presentation. Feel free to ask a question by accessing the Q&A function on the bottom of your toolbar. We will have time at the end for questions and answers. So Adam, let's go to slide 2. Let's go over today's content. So you'll see the objectives for today's program. One, we're going to describe the essential components of a diversion stewardship program, differentiate diversion risk points within the medication life cycle, and also recognize common challenges seen by diversion programs and the opportunities available to mitigate diversion risks. Now, it is with great pleasure that I will introduce our speaker for today's program. That's Adam Beeler, who you see on the screen right now. Adam is an innovative healthcare leader with experience in a variety of pharmacy practice settings. He earned his Doctor of Pharmacy at the University of Tennessee Health Science Center. And after earning his PharmD, he completed a 2-year health system pharmacy administration residency at the University of Kansas Health System, where he also obtained a master's in pharmacy practice. Adam acted as the assistant manager for controlled substance compliance at the University of Kansas Health System, where he also served as the chair of the Drug Diversion Oversight Committee and Drug Diversion Response Team. Prior to his current role, Adam was a principal consultant for drug diversion, controlled substance compliance, and inventory management at Trexan Consulting. So at this point in time, let me hand the program over to Adam. It's all yours, Adam.
Fantastic. Thanks, Matt. All right, a few housekeeping agenda items for today, and just to get you oriented with the flow of our conversation. So before we can jump into the fun stuff, we really need to define what drug diversion is. And once we do that, I want to go over what I call the diversion philosophy of your program. Once we get some of those housekeeping items out of the way, we'll talk more about a day in the life of a drug diversion program manager and some of those lessons learned and challenges along the way. And last, we'll wrap it up with some technology that you can harness to optimize your drug diversion program. So what is drug diversion? The Department of Health and Human Services defines it as the illegal distribution or abuse of prescription drugs or their use for purposes not intended by the prescriber. Most often we equate this to controlled substances, but it doesn't stop there. It can be non-controlled substances, recalled medications, expired medications, drug waste. Typically it is for self-use. However, there are cases where people tend to divert drugs for financial gain. And thinking about some of these non-controlled substance agents that are very expensive. There was a story where someone in, I believe, Florida diverted oncology medications that were thousands of dollars per dose. So you can imagine some of the financial gain that people could get from diversion as well. So now that we've defined what drug diversion is, I want to talk a little bit about building a philosophy for your drug diversion program. A lot of things in pharmacy and healthcare in specific, they have clear and cut guidelines. There's rules for everything you do. There's a purpose. There's an A to Z approach. Well, I hate to tell you that the sad truth is that diversion is very nebulous. It kind of lives in that gray area. And really, you need to take this approach of equal parts of this art and science. That art being understanding human behaviors, putting yourself in the shoes of someone who may have a substance abuse disorder, or trying to understand why someone would divert drugs and how they would divert it. So it's really that gut check to help you understand, why would somebody want to do this? What is their motivations? And then obviously the science component of this is really leveraging the scientific approach to solving any problem, building a hypothesis and, working through that to come to the conclusion that, is or is not drug diversion. And along the way, leveraging technology to help you get there. So understanding that, there's not always a right answer in drug diversion, but that's okay. And that's why you need to have this program philosophy that helps guide your decision-making. First and foremost, what I always recommend is defining the purpose of your drug diversion program. Drug diversion programs, it's starting to become this all-encompassing term that includes everything, or could include everything from opioid stewardship, pain management, formulary management, you name it. All of these components have been included in drug diversion programs. But as you get your program up and going, or as you develop or further look into your program and what you want to achieve, you really need to define what that purpose is. And first and foremost, you definitely want to start with, preventing and detecting drug diversion. If you can add things to that, fantastic. But again, making sure you have that clear purpose for the work that you're doing. Once you have that purpose, then you can really scope the work. And I really equate this to two different things. Really, it's who are you reviewing and where are you reviewing? So the users and the setting. This is really important to make sure that you have the resources and funding to allow you to do the work that you need to do, and really will guide those policies and procedures that, from a program perspective for your institution. So from a user perspective, things to consider here. Are you just looking at hospital employees? Are you looking at vendors, students, interns? Are you looking at residents? There's a lot of different users that could be viewed, including patients. I've heard stories of patients diverting drugs even in hospital settings. So making sure you have a clearly defined scope of the users you're going to be monitoring and reviewing for drug diversion, and then those practice settings as well. This is especially true for those larger institutions who have multiple sites, making sure that you're aware of all those different practice settings and making it clear what you are and are not doing, so you can really define that scope. And then lastly, and most importantly, it's determining your approach to not only preventing drug diversion, but detecting drug diversion. And this is really the work that you're doing. How are you going to do the work? What are you going to be doing? Making sure that you have the monitoring tactics and the audits in place that are providing you the value on the back end. So your inputs are giving you value and valuable information. It's providing value to your program. It's not a waste of time. It's efficient. How are you going to, it allows you to measure the success of your program. And really being flexible with this is important to make sure that there's no right way to do it. So if something doesn't work, oftentimes, you have to swap out one solution or one monitoring approach for a new one. A great place to start when considering your drug diversion program and building upon your philosophy is what I call these program pillars here, which includes prevention, monitoring, and compliance. Separate, all of these are fantastic tools to help, detect and prevent diversion. But really, it's all three of these together is where you're going to ultimately be the most successful in detecting diversion. So, sure, maybe you have some prevention tactics in place, maybe you focus only on monitoring, but again, having all three of these pillars and focusing on all three of these is where you're really going to detect the most diversion. Diving in a little bit more to each one of these pillars, we'll start with prevention and some of those tactics to prevent drug diversion. We can start with security. This is, prevention is what you think it to be. It's stopping people from accessing controlled substances or medications. It's that security aspect of it, which the security part I equate to who has access to controlled substances. Is it all of your staff? Does EVS have access to it? Is it only nursing? Does leadership have access to them? So it's providing safeguards so only a limited number of people have access to the medications itself. To go a step further is those physical barriers. Again, I equate this to a vending machine. There's the glass in front of you, so you can't just stick your hand through and take all the candy you want. This is no different of a philosophy. We want to make sure there's that physical presence to eliminate people from accessing the medications that they shouldn't be accessing. Oftentimes, this is in the form of automated dispensing cabinets, which I highly suggest, and we'll get to later in the presentation in terms of why that's so important for hospital settings. But to tie this all together, you really need those policies in place. If you don't have the policies, these are setting the ground rules for how people are to handle controlled substances and who is supposed to be handling controlled substances. So if you don't have those policies in place, you really can't hold people accountable. And if you can't hold people accountable, well, then you're not going to detect diversion. That second aspect, or that second pillar that I mentioned, is monitoring. So here, I'm oversimplifying this for the presentation, but think of this as three different buckets: auditing, surveillance, and AI solutions. From an auditing perspective, I really think of this as your simple tasks, making sure that the flow of medications from one location to the next is all accounted for. So whether that's receiving inventory or ordering inventory rather, to receiving it, or dispensing it to administration, making sure along those trails that you can account for medications throughout the process. This may include invoice audits to make sure, again, what you're ordering is received. It might include discrepancy reviews. It might include restock audits, expired audits. Again, it's tracking the flow of medications. It's, in my experience, 99.99% of the time, you're not going to find anything here that's diversion related, but it's an easy check the box thing that you should do on a daily basis, because you don't want to overlook something that could be diversion related there. The next portion of monitoring is surveillance. And beyond camera surveillance, if you have cameras, fantastic, but really think about this as more than just camera surveillance. Think about this as risk rounding or safety rounds. So going to the units or going to the areas and observing the practices, seeing where medications are kept, see how nurses and providers are handling with medications. You can learn a ton from just having that observational view of what's going on in your surroundings. And then lastly, the best surveillance tool of all are your employees and your counterparts. If they're aware of something going on, if they know what to look for, the signs of diversion, and they escalate that, those threats are typically most often actual diversion events. And so our best allies in surveilling for drug diversion are our employees. And then lastly, artificial intelligence driven solutions. And by this, I mean true AI solutions. In any hospital system, on average, there's about 60 million auditable transactions per month that occur. So think about what you're able to do in your program. 60 million, there's no way you have the time, energy, or resources to audit that efficiently and monitor all of those to identify complex patterns or identify outliers, statistical outliers. So you really need a solution that can help you do that, because ultimately you don't want to miss anything that could be diversion related. And so these AI-driven tools not only can help you find those statistical outliers, but again, they're learning from itself to only escalate those threats that you should be spending your time on. So ultimately, these three things together is the best way to monitor for drug diversion. Later in the presentation, we'll touch on where each spot you monitor for. However, I don't want this to come across as these are replacements. You really need each one of these tools in your tool belt to be successful. And last but not least, compliance. So, I would highly suggest this be a part of your drug diversion programs. for the simple fact that it's so closely tied to your DEA and state regulations, and what you should be doing and what you can't do, right? If, again, oversimplifying what compliance can look like, think of it in 3 buckets or 3 R's: registration, record keeping, and reporting. You can't, if you don't have the proper registrations, you can't order drugs, you can't dispense drugs, right? From a record keeping perspective, if the DEA were to come in tomorrow and audit you, the record keeping is where you're going to see those large fines add up. Just to provide a little context here, you have to keep records, accurate records of all of your inventory, all your prescription orders, all your invoices, purchase orders, et cetera. DEA has a long list of this, right? So imagine just 1,000 records that the DEA comes in audits, and let's assume you're 99% accurate in your record keeping. Well, each violation they find is roughly $15,000. I think with inflation, it's just over $15,000 now. But that equates to over $150,000 in fines, even if you're 99% accurate in your record keeping. So again, we really want to make sure you have all your records kept the way that they need to be kept. And also this helps prevent and detect diversion. If you're missing records, that might be a sign that someone could be diverting. Last but not least, reporting. I can't preface this enough, become allies and become friends with your DEA and state boards of pharmacy, making sure you're reporting your 222s on a monthly basis, making sure you're escalating and reporting your 106 forms as soon as possible so they can be a part of the investigation, and making sure that although you don't have to report your Form 41s, but making sure that you have those on file if they were to ask for them. Now onto the fun stuff, a day in the life of a drug diversion program manager. And again, this can vary depending on your practice setting, the size of your organization. I was fortunate enough when I was at the University of Kansas Health System that I had a small team underneath me, and my sole focus was drug diversion and making sure that we're detecting and preventing drug diversion. So not everything I say today will apply directly to you, but I hope you can kind of take bits and pieces of that and interject it into your workflows. On a typical day, it would really start with those daily audits that I mentioned as part of the monitoring tactics. It's those simple check the box things that we can do to say, yes, all the drugs are accounted for, as they flow through the medication life cycle. This really starts with your invoice, with your invoices, and making sure that everything you order actually is received into your inventory. Discrepancy reviews. I can't preface enough that you should be reviewing resolved and unresolved discrepancies on a daily basis. There's several accounts of diversion events that have happened where people, quote unquote, resolve discrepancies in the inventory count, but actually, it's not actually resolved. And so making sure you're reviewing those so all of your inventory going forward is correct. And again, restocks and expiration. So making sure that whatever you send to your automated dispensing cabinets or whatever you remove from your automated dispensing cabinets are accounted for. So, in a typical day, if everything goes to plan, that may take an hour, maybe less. If you find something here that, you need to escalate or investigate further, it could take all day. You could find diversion here, but the likelihood of finding diversion here is very, very small. But as I'll show in the next few slides, the risk is really, really high here. So you want to make sure you at least start with these few daily audits so you're not overlooking, those large diversion events. From there, typical day flows into some team meetings just to sync up on what we're working on for the day. Again, I had a small team underneath me that worked on investigations and whatnot alongside me. So we were able to sync up what's going on, who's doing what, who needs to follow up on what drugs are unreconciled, et cetera. So it allowed us to just formulate a game plan for the day and know what to do going forward. But a bulk of the day was really investigating cases. And, we were fortunate enough to have an AI solution to help, us find those cases to investigate and really drive our daily workflows. But these investigations are where you're going to find a bulk of your diversion events. These are those complex diversion schemes, whether it's medication swapping, it's practices that, develop over time. The list goes on in terms of what that could look like, but this is where you're going to find those users who are actually diverting. Healthcare, everyone is very smart, nurses, pharmacy alike, everyone is incredibly smart and intelligent people. they know what not to do to show up on your daily audits, right? So they're not even going to go for those things most of the time. They're going to, these practices are going to develop over a period of time, which is where you really need this investigative type review to identify those behaviors. And again, lastly, I don't want to forget to mention the system support that this type of role provides for the organization. There's a lot of education and awareness that has to go into drug diversion, what it means, what it looks like, what to look out for, how to respond to it. So in this position, you really are that frontline person, or should be seen as that frontline person, for educating all staff and leadership alike. From a consulting perspective, no, not outside consulting, but really consulting your operations from a pharmacy and nursing perspective, making sure that they're aware of the risks. If they go forward with a new workflow change or a new system, they're aware of any compliance risks that might pop up, or any new diversion risks that might pop up with their new their workflows. And again, last but not least, compliance. If you forget compliance and DEA walks in tomorrow, well, good luck to you. So don't forget compliance in your day in the life. So this is what I was referring to when I mentioned the medication life cycle. And I just want to orient you to kind of this concept, because the next dozen or so slides, we're going to walk through step by step of this medication life cycle, get you familiar with each step and things to look out for in each step along the way. So along the top, you'll see this arrow here, shows from left to right, lower frequency to higher frequency. Again, this is speaking to the number of transactions that occur over a period of time, right? So in any given day, maybe you place one order, maybe an order's placed once a week. So again, you're receiving that once a day, or you're receiving that once a week. But then as you go from left to right, you're going to be dispensing more than once per day. And certainly nurses are going to be administering more than once a day. So that the frequency in which medications are handled increases dramatically. On the bottom here, you'll see the arrow going in the opposite direction. And this really speaks to the quantity or the amount of drug that's being moved through the life cycle. So again, if we're starting on the right-hand side, where that nurse is administering it to the patient or wasting, the quantities that they're doing that at are very small. If it's waste, it could be 25 micrograms of fentanyl. It could be only one tablet of oxycodone. The quantities are very, very small. But as you go back to the left of this medication life cycle, back to the wholesaler, the quantities are large. You're typically ordering in bulk, whether it's 1,000 tablets of oxycodone or 1,000 fentanyl vials. So your quantities are much larger here. You may be asking yourself, okay, Adam, I get that. Why is this important? Well, as you're thinking through this medication life cycle, again, think here, these lower frequency things have higher quantities of drugs. So these are very high risk. One diversion event here on this side of the medication life cycle would be very easy to spot because it's a large quantity. And if you're doing those audits on a daily basis, you should be able to identify those fairly easy. But as you transition to the right side of this medication life cycle, where they're dispensing and administering to patients, this happens thousands of times a day. And so, there's a higher likelihood that diversion is going to happen here just because the frequency is so much greater. But what also complicates this is that the quantities are so much smaller. So it's easier for it to go undetected. So as we walk through this medication life cycle, like I said, we're going to walk through each step of this, and really it starts with ordering medications. And so whoever's placing that order, that next step is really receiving it into your pharmacy. And by that, I don't mean putting it into your inventory quite yet, but it has to be delivered and placed somewhere first. And so whoever is ordering the medications really should be separate from that receiving process because of the risks involved here. And I'm going to explain here in a second. But what you really want to monitor here is that all of your CSAUS orders are complete. You have all your 222 forms if you're still using 222 forms. You have all physical invoices attached to the inventory that was received. And you go back into your wholesaler system and confirm receipt that the medications made it to your location. So all these things are really critical to make sure that nothing is stolen at this junction. For example, McLaren Health System was fined a pretty substantial amount for a number of different things, but one of them being the distribution of C2s to unregistered facilities. So what was happening was, again, you could equate wholesaler to mean one pharmacy to another pharmacy as well if you're distributing to some of your other sites. If you're not doing that correctly and you're not checking that the medication actually made it there, then it could be diverted. So making sure you have a separation of duty between that, and making sure you have surveillance over where those medications are placed within the pharmacy. I've heard stories where they just put them on the loading dock. By all means, try to get those totes inside the pharmacy as quick as possible. Along those same lines, and to kind of finish that receiving process, is having those totes in hand and putting that drug into the inventory system. So again, you're making sure that whatever's ordered is physically in the pharmacy and physically put into your inventory. And at the end of the day, it all cancels out. There's nothing missing. There's no pluses or minuses in the inventory received. And to do this, really, you're going to look at your purchase orders, your completed invoices, and do routine inventory audits and look at those records as well. Again, the person ordering the drug shouldn't be the one receiving it, because if they own the entirety of that process and there's no double check, they could easily just take an invoice, take an entire tote, and no one would know about it because they're the one who's controlling that whole process in the system. So making sure that there's separation of duties or a double check, and making sure you're auditing this daily is really critical to make sure that there's no diversion that occurs here. An unfortunate incident at Mass General, again, a lot of these diversion cases are multifaceted, but one of those was at Mass Gen where they had incomplete or missing inventory. So, whether it was those purchase records or invoices that were attached to those totes, or, they didn't have their complete inventory records to show the flow of medication. This is why it's so important, is because when the DEA comes in, that's what they're going to be looking for. Naturally, the next step in this process is dispensing drugs, right? That's why we ordered them in the first place. That's why we have them in pharmacies, right? So from there, the drugs can go one of two places. And again, I'm simplifying this, but think of it as either going to the patient for administration. And by patient, I mean the nurse or provider who's giving it to the patient, or it's going to be loaded into the automated dispensing cabinet to then be dispensed from the nurse or provider to be administered. So we're simplifying it to those two routes just for today's presentation. But first, we're going to focus on those dispenses that are specific to those patients. So what we're going to want to look at here are those dispense records and making sure that the medication was actually received, that there's an actual handoff from pharmacy to that provider, whether it's a signed delivery receipt, whether there's some sort of confirmation there. There's a lot of ways you could go about this, but making sure that there's that handoff and responsibility to say that that nurse or that provider is now taking ownership of the medication. Another thing that I've caught on to in recent years to look out for and something to monitor are redispenses. So let's say a nurse or provider is asking for a new dose quite often. They're saying, oh, I dropped the last one on the floor by accident. Oh, the barcode was damaged. Oh, the tamper evidence seal was busted. They'll come up with a million excuses why they want you to redispense the drug. Sometimes it's because they just want the drugs, right? They want one for themselves, one for the patient. And so keep that in mind. If you're seeing a pattern of a ton of redispenses, there might be something else going on there. Lastly, another consideration here is how you're delivering those drugs. If you're using a secure pneumatic tube system, making sure that there's codes associated with it. If you're doing a direct hand-to-hand handoff, making sure that there's signature that goes along with it. The last thing we want to do is deliver narcotics to a location and they're not secure. Again, progressing through this medication lifecycle, the next step is administering it to the patient. This is by all means the most challenging part to detect drug diversion. This is almost impossible at times, because if you think about what's happening here, the nurse or the provider is administering a drug to the patient. The patient may be in the room by themselves. It may just be them and the provider or the nurse. A lot of times the patients are, they don't understand what medications they're getting. They have a list of 20 medications. They won't notice one being missing. Maybe they're on a ventilator, maybe they're unconscious. There's a lot of things that could go into it where the patient doesn't fully understand all the medications that they're receiving, and there's no way for them to validate that. And if it's just you and the patient in the room who's sleeping or can't respond, well, it's easy enough just to scan the barcode, say you administered it, and then put that in your pocket. It's unfortunate, but I've seen it happen. And I've caught diversion here. But the way to catch diversion here is through those practice patterns. And it's, again, utilizing your AI tools to identify those patterns. And again, it's going to be very difficult to find diversion the first time somebody diverts, unless it's blatantly obvious or an unfortunate accident where someone, overdoses and they're found overdosing the call room or bathroom. And that's a rare minority, but to identify diversion in this practice setting, really you need to look for those patterns over a period of time. How is their behavior changing? How is it progressing over that period of time compared to their peers? And this is where you're really going to find those people to investigate and look into further. But again, you're also going to want to monitor administrations and redispenses for the same reasons I mentioned on the previous slide. As I mentioned, it's really hard to confirm drug diversion here. It's hard to confirm that the medication was given. And another thing to consider here is this is an easy avenue for drug tampering. It's very easy for a provider or a nurse to give normal saline instead of fentanyl. They look the same. It literally looks like water, so how is a patient going to know the difference? Maybe they know based on their pain control, but again, diverters are smart. Maybe they're giving 3 different pain medications to cover up the fact that they didn't give the fentanyl. So understanding that drug tampering can happen here is something to consider. I don't know that you can stop it necessarily, but again, just something to know if you're detecting diversion here, you may want to look into drug tampering as well. So instead of dispensing directly to the patient, the other avenue is dispensing it to the automated dispensing cabinet. So it's going from your central inventory to your dispensing cabinet. And typically this process is managed solely by pharmacy, but you want to really make sure that whatever is being dispensed makes it to that cabinet. So if 50 fentanyl vials were dispensed, 50 are received. There's no corresponding discrepancies at either your central inventory or that cabinet, and everything is accounted for. You're also going to want a separation of duties here to make sure that the amount dispensed, one person is doing that, they're dispensing from your central pharmacy. A second person is validating the amount dispensed, and that second person is also the one that is putting that in the machine. So, for example, if I were the person to dispense and load the medications, it would be possible for me to say I dispensed 50, maybe I'm only loading 40, and then I take 10 for myself, right? So there's a lot of ways that people could divert in that process if you're not monitoring it. This is one of those things that you can audit fairly easily on a daily basis, depending on your automated dispensing cabinets and the reporting capabilities you have there. One example was Soba Health. Again, these diversion settlements are multifaceted, but one of those facets was that the technician was sending inventory to a ghost cabinet. So there was a cabinet on the server that they could choose to send drugs to dispense drugs to for restock. However, there was no physical cabinet present. So this tech was pretty savvy, figured out, hey, I could load up, I'm sending 100 oxycodone tablets to this cabinet, but really nothing was being loaded. And since there was no physical cabinet, they weren't auditing that. So again, keep in mind the risk point here. Again, very similar to that the patient-specific medication to administration, the automated dispensing cabinet to administration is no different. We're going to really focus in on practice patterns here. We're going to look at discrepancies. And again, this is one of those daily audits that you can do. Again, nurses and providers are very savvy. If they want to get caught, sure, they'll create discrepancies. 99.9% of the times, they know better not to create a discrepancy. And so they're going to manipulate either their documentation or what they're actually administering and divert a different way because it's so easy to detect diversion via discrepancies. So again, they're trying to bypass the system and find another way to do that. So things to consider here, again, falsification of records. As I mentioned previously, depending on the patient and the status, it's very easy to scan a barcode, said you gave something, or, for example, let's say you have a patient who takes oral oxycodone solution and they're taking 40 milligrams. By what I'm aware of, that's 8 different cups, 5 milligram by 5 ml cups. So you could give 4 cups to the patient and then take 4 for yourself. The patient may never know, right? So there's a lot of things that can go wrong here, including drug swapping. So I've actually caught a diversion event where the individual was dispensing non-controlled substances along with oxycodone. And it was our AI solution that helped us identify this. But what they were doing was giving little white round tablets to the patient, whether it was topiramate, blood pressure meds, you name it, hydroxyzine. There was about 30 different medications that were white and round and looked like oxycodone. And that nurse was taking the oxycodone for themselves. So just know that this is an opportunity for drug swapping as well. Again, this Cheshire Medical Center is still under investigation. This is a more recent story, which I'm sure you guys were all made aware of during the height of COVID. Over the course of, I think, over a year, maybe 18 months, a nurse had diverted over 583 fentanyl drips. And I think the news headline said something to the amount of like over 7 gallons of fentanyl. I mean, everyone on this presentation knows that's not how we measure fentanyl, but again, it's eye-popping when you see that amount, and certainly 583 drips is an incredible amount to be diverted. And again, they were doing it by dispensing it and not administering the medication. The next step in that process is, any waste or returns that have to happen. So whether you're returning it to the automated dispensing cabinet or whether you're wasting it and documenting that waste at the automated dispensing cabinet, waste is a massive, massive target for drug diversion. Some things to monitor here are practice patterns. People, again, are super savvy. They're gonna try to trick their peers to say, oh yeah, this is fentanyl. You saw me waste that, right? Can you just document here, blah, blah, blah. They're gonna try to come up with those excuses. But if you look at those people who are trying to get their hands on drug waste more than others, this may clue you into the fact that they could be targeting drug waste as an avenue for diversion. So something to keep in mind, and really utilizing your AI software to identify those patterns. If you're fortunate enough, you can do waste assays of your drug waste. Again, this becomes very complex and very difficult to produce at scale at all those locations where you're wasting, but you could certainly do random audits with that as well. And then camera surveillance here. A lot of times this is not confirming diversion, but ruling out diversion, corroborating what someone is telling you. But you could see if you have cameras in your bedroom or wherever they're wasting, surely you could look to see if they actually perform that act. Another cool thing to mention here is preventing drug waste. So again, how do you prevent the diversion of drug waste to begin with? Well, you prevent waste from occurring at all, right? So if you have alignment with your formulary, if you eliminate range orders, and if you have the right products stocked based on what is typically administered on your unit, for example, let's say your unit typically gives 50 micrograms of fentanyl per dose. Stock a 50 microgram per 1 ml vial or syringe instead of the standard 100 per 2. Sure, it might cost more, but not only are you reducing the threat of diversion, but you're also saving the nurses a ton of time from having to log that waste transaction. So it's a win-win there, although there is probably a little added cost. Other things to consider in alignment with the administration piece, it's easy to falsify records. It's easy to swap drugs at this point too. Again, fentanyl looks like normal saline. There's 50 different pills that look like oxycodone. So you could easily dispose of something else, and the person who is witnessing you do it think you're actually wasting the drug, but wasting something else entirely. Again, another unfortunate DEA settlement at UT Southwestern. Again, these are multifaceted, but one of those was nurses diverting drug waste. Again, unfortunately, it led to 2 nurse fatalities. But again, that's beside the point. It's really just hammering home the fact that diversion can happen at each and every one of these steps. So once you've kind of gone through that cycle, again, on the back end, you have medications that are expired, they're recalled. Maybe they're unassigned from the cabinet because you're optimizing your inventory. So you have to remove them from your automated dispensing machines. And, if it's unassigned, sure, it can go back to your central pharmacy. If it's expired or recalled, it really should go to a segregated area so that drug can't be used. But you want to make sure whatever is removed from those cabinets makes it to that designated location. And you want to do that whenever that occurs. So on a daily basis, be auditing to make sure whatever's removed from your cabinets makes it back to your pharmacy if that's the case. And again, common themes here, making sure that there's a separation of duties for all of these different functions, or a second sign off on it if you can't have two people do it. And then making sure you have a designated location for those expired and recalled medications, because those are actually part of your inventory until you get rid of them, whether it's through a reverse distributor or through destruction. So it's very important that you actually have that inventory and you know exactly what you have in that inventory until it's gone from your facility. A more recent example is Northeast Hospital Corporation. They were caught expiring over 17,000 C2s from automated dispensing cabinets, and they didn't account for them in their inventory. And so essentially they're expiring them. Technician or pharmacist, whomever it was taking them for their own use, and they were not accounted for in the expired medication inventory. And then lastly is that reverse distribution step. So again, if you have that holding spot with all your expired medications, your recalled medications, making sure that whatever was removed from the cabinets is the same quantities you have on hand there, and is the same quantity received from your reverse distributor. So making sure all the stars align, making sure there's no missing inventory between those steps. Really, you can do this by just auditing your expired inventory in that 222 form that you receive from the reverse distributor, making sure that, again, there's separation of duties between these steps, and then those drugs are held in a designated location. So now that we've talked about the medication life cycle, what to monitor at each step, I don't want to forget to mention the leadership and advocacy that really comes along with this role. I briefly mentioned on a previous slide some of those consulting and committee involvement opportunities that there are, but again, just want to surface that here to say that you are that person to consult on operational changes. No one else in your organization is going to have that knowledge level that you do in terms of the risk for drug diversion, in terms of the risk that you have from a compliance perspective. So make sure you're championing those operational changes, make sure you make people aware of the risks involved with those changes from both a compliance and diversion perspective. And again, depending on your involvement and how far along you are with your diversion program, making sure you have a diversion oversight committee that helps guide your policies and procedures. You may sit on the opioid stewardship committee or be a part of med safety initiatives as well. So now that we've talked through, that day-to-day and some spots to monitor, really want to talk through some of those high-level lessons learned before we get into some questions. So first and foremost is communication. Like anything in life, you need to be a good communicator to make sure everyone's on the same page, especially when we're talking about individuals who are diverting or suspected to be diverting. Their job, their livelihood might be on the line. So you want to make sure all your T's are crossed, your I's are dotted, and you need to have a systematic approach for understanding how information will be shared and with whom. So from an internal perspective, making sure your diversion team is looped in, making sure you understand how that communication is coming across, whether you have a committee meeting to talk about these things and you have meeting minutes, whether it's all via email or, a third-party vendor, your AI solution, whatever it might be, making sure you have that base where all that communication is held. Same thing goes with leadership. How are you communicating these events to your C-suite and beyond? How are they made aware of these events? What are you communicating with them so they can, help you get the resources you need to prevent further events from happening? And lastly, the suspected diverter, gosh, I've never been in those shoes, but I can only imagine how frightening it might be, especially if you have a substance abuse disorder. You may not know what resources are at your disposal to get help, and you may not understand the process and what those next steps are. And so really making sure that it's clear that that person understands who that communication is coming from, what resources they have, and making sure that messaging is consistent is really important for your program. And from an external perspective, it's along the same lines. It's just making sure that you have that systematic approach for that communication. And I would strongly advocate for you guys to all become, friends to an extent with your local DEA office. Ask some questions. Don't just always reach out to them when there's problems that come up. Make sure that you're engaging with them early on, and that really builds that trust and communication. But also, you need to make sure that your messaging is consistent between DEA, state licensing boards, and law enforcement as well. So I would always suggest that comes from a sole source, making sure that messaging is consistent across the board. The next challenge is really program standardization and defining how program activities are completed on a day-to-day basis. How are you going to monitor for drug diversion? What do the audits look like? How do you audit? What does an investigation look like? What are you doing in an investigation? What are the steps? So making sure it's clearly defined what that looks like. So if someone's on PTO or you have a multifaceted team, someone can step in and do it consistently to remove that bias in the investigation and really stick to the facts. And again, you need to remain consistent across roles, practice setting, and level of concern. Obviously, if there's a large diversion event versus a small one, you're likely to, pay more emphasis on the large one, rightfully so. But, the penalties for a small diversion event really shouldn't be any different for your healthcare organization than a large one, because diversion is diversion. The DEA considers it all the same, no matter how much is diverted. So making sure you're consistent across your roles, whether it's a pharmacist, a physician, a nurse, a student, it doesn't matter, along with the practice settings, making sure that all of that is the same. In the corrective action, making sure that's the same as well. And lastly, making sure that consistency day to day, regardless of the auditor, every audit is done the same. There's a checklist. They know exactly what to do, when, and why. Lastly, challenges with monitoring and auditing. There's so much we could be doing and we just don't have the time to do it, time and resources. So making sure you're prioritizing your efforts so you can effectively, detect and prevent diversion. Again, starting with those daily audits, starting with some of those prevention measures. Then maybe you have more resources that funnel into your team to do some of those more investigations, but making sure you're prioritizing your efforts so you're doing those things really, really well each day, and making sure you know your limits, your limitations and restraints. So I always say it's better to do one audit really, really well and consistently than to do it haphazardly or do it sporadically. So don't try to spread yourself thin to do too much. Really focus in on those things that you can complete on a daily basis. And as time allows, as resources allow, let that grow into other things. And by all means, leverage technology for maximal coverage. As I mentioned, 60 million auditable transactions per month in hospital systems. There's no way you or I or everyone on this call could even do that in a month and find diversion the same way. So leveraging technology to make life easy for you is really where you're going to get the best bang for your buck. And lastly, I mentioned it, with some of the consulting processes to consider, but making sure you're up to date and aware of any system upgrades and workflow changes is huge. So whether you have an EMR upgrade or an automated dispensing cabinet upgrade, maybe nursing is working on a new initiative, for medication administration and handling, you want to get ahead of that so you can develop monitoring tactics that are in alignment with it so no one can exploit these new system upgrades or workflow changes, because I guarantee if you do not, someone is going to exploit it. If anything else fails, from a harnessing technology perspective, please, by all means, focus on these core systems for hospitals. You're going to want to have an electronic medical record at all costs. You want these things electronically documented to have that record. Paper trails are extremely hard to follow. Same thing with perpetual inventory systems. If you can have your inventory system in automated dispensing cabinets or another mechanism to audit that electronically, it's going to be a lifesaver for you to do a lot of these things. It's almost impossible if it's all done on paper. Not to mention, paper is very easy to manipulate. And if you lose a piece of paper or you write the wrong number down, everything goes haywire. And so really relying on these core systems, including electronic ordering and reverse distribution as well. So again, if you think about that medication life cycle, these core systems here will allow you to monitor each step in that medication life cycle. So by all means, this is where you should start if you're looking to harness technology. If you're looking to take that next step and add some fundamental components to your diversion program, I would suggest starting with an AI software solution. Again, it's maximizing that coverage. It's identifying those people of high risk and concern, reviewing 100% of the transactions on a daily basis. Whereas you and I, maybe we get to 1%, and who knows what we're missing if we're doing that. So really leveraging and leaning on technology to do the hard work for you, so you can only focus on the true diversion threats. Again, camera surveillance is a great tool to have if it's at your disposal. It can help you confirm diversion, but more times than not, I think it helps you rule out diversion, helps corroborate stories, which again, it's a great tool to have for staff to make them feel secure. In making sure that they're not wrongfully seen as diverting when they're actually doing the right thing. And then badge readers is another thing to consider. If you're badging in and out of certain locations where medications are stored, that creates an electronic trail of where you've been, and that record can then be used to help you determine where that person was. A perfect example of this is I had a nurse who was, quote unquote, said to have been administering a medication at a particular time. You look at their badge reader access, you look at the cameras, and they're in the medication room. So clearly they could not be administering the medication when they're in the medication room and not by the patient bedside. And if you have all of these systems in place and you're really looking for that next jump in technology, really look into the drug waste analysis assays and technology that's out there. This is a growing field. There's a ton out there. But this is going to help you potentially eliminate the need for a witness, because a lot of these tools will validate what is being wasted. Some of them can validate the amount being wasted. So this is a growing field, definitely look into. And fully integrated smart pumps. I can't advocate for these enough, not only from a diversion perspective, but a medication safety and patient safety perspective. I read a recent study that said that only 10% of health systems have fully integrated smart pumps. And by that, I mean, they're keying in what they're doing at the smart pump, and that information is automatically flowing across to their flow sheets and their EMR. So a lot of times, current state, you're typing in the rate change, then you have to go to the computer system, change it in that as well. So really leverage that to eliminate diversion threats as well, or identify diversion threats. Last but not least, medication tracking. There's a ton going on with this, with RFIDs, tags on certain medications. This goes for both retail pharmacy and inpatient pharmacy locations or inpatient settings. So a lot that could be used with the medication tracking tools that are out there. And wow, that was a lot of talking. So I'm really looking forward to answering any questions you guys have.
Thanks, Adam. Thanks for a great, thorough presentation. Too many questions and too little time, Adam. So let me try to get some questions in as much as we can. And everyone recording the session, again, to repeat, this is going to be available on ISMP's YouTube channel and website, sometime probably by next week. So this program will be there with the questions and answers as well.
And Matt, I'll just add that I'm willing to answer any questions that are in the chat that we don't get to today. I don't know if we have a forum with ISMP that I can post those to, but I'd be more than willing to do that.
Yeah, if I can figure that out, Adam, I'll try that.
Sounds good.
So I want to ask some basic questions about the program. So I'm going to make the assumption that people on this phone call don't have much in place now as a drug diversion program. They don't have a person like that with the role that you had in Kansas. So how do they start this drug diversion prevention program and monitoring efforts today?
Yeah, Matt, I think the simple answer is starting small, starting with doing those daily audits, and maybe you're the champion for drug diversion and you're divvying up some of these tasks to local site leaders. Technicians are great people to do some of these audits as well. So again, it can be a team effort, and oftentimes it is. And that is an easy way to kind of get your foot in the door and show that you really need those resources. And the thing with starting a program, more often than not, and the unfortunate truth is, a lot of times you get the funding after a bad event happens, which again, we don't want that to happen. So if you get your foot in the door, kind of spread some of that work out, then you can start introducing the conversation for more resource. And I've seen that to be effective.
Adam, how did you measure if you were successful? Right. So you got this, like a lot of people involved where you work, a lot of activities going on. So what is your measure of success? Like, what is there some numeric denominator you could measure, or how could you go to leadership to prove, listen, I'm worth my salary because here's proof because of X? What would you show them?
Yeah, fantastic question. I'm glad you brought that up. So it's not like a lot of things out there in pharmacy or in healthcare where we can have a denominator of what we're trying to look at. People are not out there waving their hand saying, hey, I'm diverting, count me as part of the pool and try to find me, right? They're not doing that. So we can't focus on number of diversion events detected to be that answer. I'm sure you want to detect as most as possible. And I don't think if you catch 10 diverters or 2 diverters, that's good or bad, but understanding that, there's potentially more out there. And so how I measure success for diversion programs is through process improvement. And really this boils down to time and your efficiency. So how much time are you spending doing these particular activities? For example, how long does it take for you to investigate a case from start to finish? How long does it take from day one someone diverting to when you catch them diverting to when there's corrective action taken on that person? So measuring that time is one parameter. But from an efficiency perspective, measuring the activities you're doing and the outcomes you're achieving. So I coined this as your violation rate, how many diversion cases and how many violations you find over all the work that you're doing, all those investigations you have. I find that a lot of my colleagues have a rate around 40%, which means that 60% of your time is wasted going down rabbit holes. So how can you look into your processes to further eliminate that so you're only focusing on those high risk diversion cases?
I know. Now, we had 2 questions earlier regarding just the phrase audit, right? So first off, is there a percent? You can't audit everything. So it's a percent of charts is one of the questions. The other one is just defining that audit is that, obviously the chart reviews is one example. There's all this data mining and other surveillance software. So define that an audit can become different flavors depending on the size of the audience too in their organization. So define that audit, what it means and what you're looking at.
Yeah, great question. How I define an audit is the easy ins and outs, the flows of medications. You're dispensing it from one location, you're expecting it in another location, and you can close the gap very easily by saying, yep, 50% from here, 50 were received. To me, that is an audit in each step of that medication life cycle. So it's those simple tasks, just making sure the flow of medication gets to where it needs to be. Chart reviews certainly can be considered audits, but if we're looking big picture, and if you're fortunate enough to have an AI-driven solution, chart audits often become obsolete because those AI tools are surfacing only those users with the greatest concern to investigate further. And so instead of spending your time digging through charts, trying to find the needle in the haystack, let the AI and let the technology work for you and surface those events for you to further investigate.
Mm-hmm. So let me ask a question. Do you have a relationship with a local DEA agent? Would you recommend that? And if you do, what does that look like? You ask them out to lunch? Like, how do you do this?
No, we had never gone out to lunch with them, but it's as easy as just asking them simple questions and introducing yourself. When I took on the role as program manager, I just reached out to the local office and said, hey, my name's Adam Beeler. I'm the new program manager. I just want to make sure I have the right contact information for who I should talk to if there is a diversion investigation, if I have to file a 106. They're more than happy to work with you. And then from there, it just escalates to more conversational things. You may ask and reach out to them to clarify a DEA regulation or how they may interpret something or what they would be looking for when they come on site. Or maybe you're trying to determine, do I fill out a form 41 for destruction on this, even though I know it was accidentally thrown away in the trash can? So like those questions like that is a great way to introduce yourself to them. And I mean, by all means, if they agree to lunch, go for it, but they're super friendly people. They want to help you. And if you build that relationship, it really shows that you're trying to do the right thing instead of being, quote unquote, the bad guys.
So I'm going to ask one more question. Now, this person is asking about nursing buy-in, but I'm going to expand that to even anesthesiology buy-in, because I know, our experience visiting hospitals, there's always these things laying around just in case, and anesthesiologists will take up more than they really need just in case, but also getting nursing buy-in, because I'm sure from the nursing end, this presentation is coming across all pharmacy, right? But we need to have nursing a part of this. So how do you get both of those disciplines involved?
Yeah, so it can be challenging, but you do need a champion. There's going to be someone out there who is passionate about this. It can be hard to identify that right person. I would say that's probably the hardest part. But again, what I was able to do is show them the difference between our legacy program and our old tactics versus applying some of these new technologies to our program, and showing them how much easier it would make their life. For example, instead of sending them a report on a monthly basis to audit their users, I would simply just escalate a case to them and say, hey, we think this is diversion. Let's talk, let's review this and talk about next steps. So, their focus is on time. They don't have enough time in the day to do all these things. So, if you can leverage that to say, hey, the things that we're doing, the things we're putting in place is going to save your team a ton of time. That's an easy way in with the nursing staff and anesthesia staff for that matter.
Yeah, I'm seeing comments come up here because obviously people are having pushback from the anesthesiologists too, and their practice area. And everybody, listen, we appreciate that because there's always an average point. Like someday, if a DEA agent walked in anesthesia, someday they're gonna be shocked at the practices they find there. And believe me, they don't want to find out the hard way. So that's why it's really important. I definitely appreciate the pushback, 100% of that. But yeah, being on the receiving end of DEA investigation is not where you want to be either. So
yeah, absolutely.
So on that note, listen, we get a little past the hour here. So first, I would got to thank Adam for the great presentation today. Two, I would got to thank Fresenius Kabi for they're the ones who sponsor this program for us today. So we have a free webinar for everybody. And also on the slide, you'll see the link here. And you just go to our website for the next webinar on March 15th. We're going to do a part 2 of this series. So in part 2, the title being Reducing the Risk in Infection Outbreaks from Drug Diversion, we're going to have 2 speakers. One's going to be a system-wide risk manager to give their perspective of diversion as a risk manager. And the second half would be someone who's an infection control preventionist to explain, the role of infections and diversion too, because, there's some things that happen that lead to infections because of diversion. So we're going to get those 2 topics covered, register on our website. And on that note, I want to thank everybody for joining in. I want to thank everyone for the great chatter in the chat box and questions. And thanks for joining us for today's program. And we hope to see you next time. Thank you.
Thanks, everyone. Take care.